Okay, good afternoon, everybody, or good morning, depending where you are logging in from. So just to go over some housekeeping, just before we start our CHHA Cochlear webinar with Q&A with Camille Lacasse, Doctor of Audiology, I want to make sure that everybody can hear me okay and that you're seeing the closed captions. If you don't have the closed captions activated yet, if you look at the bottom of your bar, you should see a closed captioning button and have a CC, and you can turn them on. So if you want to just go ahead and try that, make sure it's working. I'll give everybody a few minutes. Also, during the presentation, if you like to ask questions, we will have a period for Q&A. We'd like everybody to type them in the chat. This way, in case we miss some of the questions, we don't have enough time to answer them, we'll make sure that we get the answers to everybody, and we'll send an email after the webinar. I'll give everybody another 30 seconds to make sure everybody's closed captions working in case we have some people having technical difficulties logging in. Okay, so on behalf of Cochlear Canada and CHHA, I would like to welcome everybody to today's second webinar over from our four-part series webinars. Today we have a special guest speaker with us, Camille Lacasse, who you'll get to meet shortly. But before we begin, I would just like to do a little introduction on who I am. So my name is Dorota Simpson, and I'll be your host moderator for today. I'm the engagement manager for Cochlear Canada East, and I've been with Cochlear for about 5 years now. But my journey began with my son, Lucas. I have two boys. Lucas is now 13 and Reed is 11. My older son, Lucas, was born with a progressive sensorineural hearing loss. So he started off with hearing aids, and every time we went to see our lovely audiologist, unfortunately, his hearing kept on declining. So pretty much every 3 months, he would lose some decibels. Then when he was 3.5, we were told that now he's a candidate for cochlear implants. And again, this was something very new to us. And even though Cochlear has been around for 40 years, I had no idea what a cochlear implant was until we were told that he's a candidate for one. His journey began with cochlear implants, as I mentioned, when he was 3.5. But what really helped us get through the journey is having the support from many mentors, many other recipients, and many other parents, on top of all the professionals working with him. So today you'll hear a little bit more about the support that not only Cochlear can provide, but also a Canadian Hard of Hearing Association. We both share a Connect with a Mentor program. So for those of you who are either starting your hearing loss journey or you're with your loved one or are thinking about having a cochlear implant surgery, please be assured that both of us, we have amazing support available for you throughout the whole journey of your hearing loss. My son Lucas right now, he's an athlete and he's also an aspiring actor. So for those of you who like to watch TV, look out for him for an upcoming commercial on Canadian Tire, and he'll be in the scene playing soccer. So keep an eye out for him on that. Our mission, one of the things that really drives me working for Cochlear and many of the employees working for Cochlear is our mission. And this is something that we really share with CHHA as well. We both want to help people hear and be heard. We want to continue to empower people to connect with others and live a full life. We transform the way people understand and treat hearing loss. Both of us do a lot of advocacy and spread awareness about hearing loss. As I mentioned in my introduction, until my son Lucas was diagnosed with a cochlear implant, I didn't know that cochlear implants existed, and they've been around for 40 years. So we want to continue and spread awareness about the technology and solutions available for individuals with hearing loss across Canada and across the globe. We innovate and bring to market a range of implantable hearing solutions that deliver a lifetime of hearing outcomes. Today you will hear from Camille on the different types of hearing losses. So we have different types of solutions available, whether you have a sensor in your hearing loss or you have conductive hearing loss. We have solutions available for both types of hearing losses. So again, this is something that we want to make sure that we help others depending on the type of hearing loss you have. There are different solutions available for you. Today's a little bit more about our guest speaker, in case you didn't have a chance to read her bio. So Camille Lacasse is a doctor of audiology. She attended the Ottawa University, where she received her master's degree in audiology. And to further her studies, she completed an advanced certificate specializing in tinnitus and hyperacusis from LaSalle University. She went on to complete her doctorate in audiology from University of Florida. Since graduating, Camille has gained experience fitting and programming both hearing aids and cochlear implants, working with electrophysiology, as well as helping people deal with tinnitus and hyperacusis. Camille is now working for the Ottawa Civic Hospital in the cochlear implant program. And without further ado, you will hear from Camille in a minute. But before we get into our speaker, it's always great to learn a little bit about the audience. Doing virtual webinars, it's really hard to know who is in the audience without seeing you, without seeing your beautiful faces and hearing where you're coming from. So I'm gonna pause for a second and stop sharing my screen, and we're gonna do a quick little poll, just 5 or 6 quick questions. So if you can take a moment to answer those, and then we'll turn it over to Camille, our guest speaker for today.
Thanks, Dorota. If you could also please check your chat box, that'd be great. Thank you. Another 30 more seconds for the poll. And we're ending our poll. Thank you so much for participating.
Good afternoon, good morning, everyone. My name is Camille. I'm one of the audiologists at the Ottawa Hospital, and today I will do this presentation with you. At any point, if you do have questions, please let me know. Same thing, if you feel that I'm chatting a bit too much, please let me know. I tend to be a chatterbox. Then, before I start this presentation, one thing I want to mention is I try to reflect as much as possible what is happening within our cochlear implant department. That being said, depending on which province you're living in or your age group, sometimes it can be a bit different. Please make sure if you have questions or if you're from another province, there is resources we can guide you to if you have a bit more specific question that you feel I didn't answer today. Our program is located in the Pardel Clinic in the Ottawa Hospital. We are part of the audiology department, which offer. Oh, you're seeing my presentation. Okay, thank you for letting me know. Let me change that. Okay, thank you so much, Arturo. Let's go here. That will be better. Perfect, and hopefully that would work a bit better. Thank you for letting me know. Okay, here we are. Is that better now? We'll say that it's still in presenter mode. Oh God. Okay, just bear with me. Just one sec here. Thank you, Arturo. Sorry about that. Share screen. Okay. Just bear with me. Sharing screen now. Okay, and what about now? I think we tried earlier and it was working a bit better.
Yes, it's working now.
Okay, perfect. Thank you so much. Okay. Then as part of the Ottawa Hospital, we are servicing a pretty large geographic area, which would include most of Eastern Ontario and extended into Northern Ontario. That being said, we do occasionally see patients outside of this traditional service area, which would include, for example, out of province. Those patients will be by case. One thing that is also important to know is people that are not in our service area or out of province may have, for example, wait time a bit different than our patients that are in our service area. That would really be on a case by case. Then, as I was mentioning before, we are located in the Ottawa Hospital. Those are our coordinates. At any point, if you do have questions, please feel free. You can give us a call, email. We are a pretty open book type of team where we like to hear from you. And if you have questions, feel free to email us. There's always somebody around to make sure we can answer your questions. As part of the team, we are currently 4 people in the audiologist. We do have a program assistant, Christine, who's pretty much our savior most of the time, and we have our surgeon, Dr. Schramm. Perfect. A lot of my patients will often tell me that they experience social isolation, that they feel alone, they feel like people don't understand them. That being said, when we look at those numbers, and that's why I pulled some statistic on hearing loss, I find it quite surprising when we see that half of the population age 40 to 79 will demonstrate at least some mild hearing loss. I think one of the issue is that, especially in those first stage, people tend to not talk about it or keep it for themselves. But then looking at those numbers, should we not be more comfortable to discuss about it? And that's something we're seeing all the time. People that waited sometimes too long before seeking help just because they were not comfortable to discuss about this. Another statistic that made me think a lot was when we think that hearing loss is the second most prevalent cause of disability after depression, then there's way more people suffering with hearing loss that we actually think. And I think that's why it's so important that we talked about it. Then you may ask, what is hearing loss? I think we have to discuss about it. Then a person is not able, hearing loss is when a person is not able to hear as well as someone with normal hearing. What's normal hearing? It's threshold of 25 dB and better in one or both ears. That's what we would consider normal hearing. Hearing loss may be mild, moderate, severe, or profound. It can affect one or both ears. There's no pattern on what hearing loss should look like. We will see in our office people with really different background And one person may present with a mild hearing loss, and the other person with the same background, same history may present with a severe hearing loss. And every day we'll see people with very different level of hearing loss. Now you may ask me, what caused hearing loss? The short answer is a lot of things. But if we look at this list, I would say that the first three that are listed are probably the most frequent type of hearing loss we encounter on a daily basis in our department. That does not mean that if your hearing loss or the cause of your hearing loss is not listed, that you will not be a candidate. It's just we're more used to see those three first when we're looking at candidacy. I actually really like this slide because through your journey with hearing, you may have heard about, oh, you have a sensory neural hearing loss, a conductive, a mixed hearing loss. And I find sometimes it can get confusing on what is what. This is why I really like this graph, as it shows a brief overview of some different cause and how we can differentiate the different type or category, if you want, of hearing loss. Once again, there's probably way more cause of hearing loss we could put in this graph, but let's say we took the main one. Then when we look at sensory neural, mixed, and conductive. Conductive hearing loss is when a sound conduction is impeded through the external ear, the middle ear, or both. Then there's actually a physical blockage that prevents the sound to go to your inner ear or the cochlea, the organ of hearing. Sensory neural hearing loss occurs when there is a problem with the cochlea or the neural pathway to the auditory cortex. Mixed hearing loss is basically a mix of both. Then you have a bit of conduction and a bit of sensory neural hearing loss. I really like this picture, and this is one picture that I will show quite often to my patient, just because I like that we have a visual. A lot of you may have been told that you had hearing loss, and it was related to a loss of hair cell or stereocilia, which I find extremely abstract. What are we talking about? I have a little hair in my ear. Personally, I always found that a good picture is often the best way to really see what we're talking about. On the right, actually on the left, you're seeing what we call a normal cochlea. As you can see, I'm gonna try to show you my pointer, or you can see those little air cells all across the cochlea, those little little line. On the right side, what you're seeing is what we would call a damaged cochlea. Then you're seeing there's a big portion, there's just not those little filament, if you want, or those little hair cells. A big portion doesn't have those. In order for an individual to hear, we would like a good coverage all over the cochlea. Then, for example, for somebody like this, in the area when there is no hair cell, it means that in order for them to hear properly, we have to make it so loud that it's actually the other hair cell, the one that are still there, that will pick up this sound. The issue with that is at some point we have to put it so loud that it's just too much sound, if you want. And this is why a lot of patients will say, it's not that it's not loud enough. It's not that I cannot hear the sound. It's just not clear. It just feels too much. And this would be the reason why. And now some of you may want to ask, what will happen if I don't treat my hearing loss? There is several statistics, as I put out there, but to be honest, the effect can be very devastating. And this is something we're seeing every day with our patient. A lot of patients, after they decided to go with a cochlear implant, they will often tell me, why didn't do that sooner? I think it is all about the unknown and the fear of what will it be? Would it really be better? How it will change my life? How it will make it better? I also think many people don't remember or don't know what the hearing world is like. Am I really hear the crackling of my foot on the floor? Will it drive me insane? And it is normal. There's a lot of unknown when we're starting this process. And they feel like it can be overwhelming. I think this is why we're seeing that people are waiting that long before seeking help, either in our department or for hearing aid. And that's why we really need to build this really good relationship with our patient to make this process easier and more comfortable. And let's start with when amplification could be the right option for you. And when people are ready, the first step is usually to look into hearing aid devices. And believe me, it can be overwhelming. There is many company, many model, and many clinics. How to know which is the best option for you? To me, the most important, and this is why I'm telling all my patients, and that's why I'm telling all my patients, is that you need to find a clinician that you trust and that you're comfortable with. You need to find somebody that you won't hesitate to tell them if you're not happy or if you need adjustment. It is not true that a hearing aid is something we program once, put in your ear, and forget about it. It needs some follow-up. To me, in order to make this a successful experience, to me, in order to make this a successful experience, you need to develop trust with your clinician. Several factors will influence which device we will recommend for you. To me, it is very important that your clinician asks you about your lifestyle. What do you like? What are you doing? How's your dexterity? Are you good with small object? Or the other way around, you want something easy that you took off from a box and put in your ear. To me, that's important. Another key factor that I want my clinician to ask is, what's your budget? To me, it's something that sometimes some clinicians feel not comfortable to ask, but also some patients don't feel comfortable to say, this is out of my budget. And that's something you should be comfortable to say. It is not always true that you need the Cadillac. It depends on your lifestyle. It depends on what you're seeking for. And this is something you should be comfortable discussing with the clinician you're seeing. The same way, if you're going somewhere and they say, here's the one, they didn't ask you a question. They didn't ask you about your budget. They just say, that's the one. To me, that sounds wrong. They should learn who they are speaking with before giving that type of recommendation. Lastly, and probably the most important, is the level of hearing loss. This is extremely important, and that should be taken into account. Or often we're seeing people coming in and the device they have does not fit whatsoever their level of hearing loss. And then we take a device that is more appropriated. They can hear better. And this is all different points that to me are extremely important. And you may ask, what's an hearing aid? And how does it compare to a cochlear implant? And let's start with the hearing aid. The goal of a hearing aid is to carry sound from around you to your ear at a proper level. An hearing aid is programmed to provide amplification of sound at different frequency on the hearing loss in regard of your level of hearing loss. It's not about increasing all the sound or just make everything louder. We need to be very specific and to adapt it to your hearing loss. This is why, for example, we don't recommend that you use somebody else's hearing aids. Maybe too loud. It may even cause more hearing loss. It is very personal and very different to each other. And that's why we really need to make a good effort and make a good job when we try to program them for you. In the case of severe or profound hearing loss, the damage to the cochlea, the inner ear, then we're seeing my famous air cell over here. is often so significant that even powerful amplification will not be enough. The sound will be distorted and the benefit will be extremely limited. Consequently, people with severe to profound hearing loss may not hear very much, even with hearing aid, and become tired easily due to the great effort required to make sense of sound. Once again, this is extremely important to me to discuss about this. How often am I seeing patients coming in with their loved one and the family will complain that they don't listen? But really, the access to sound is so limited. One thing I will always make sure to clarify, to me, there's a huge difference between I'm hearing and I'm listening. You may hear sound, but it may not be clear, as you may hear, but you're not able to really listen what the person is saying or the meaning. Then there's something we have to take into account. It's not about volume, and we should not always think louder mean clearer. There's a limit to that. Then what are the signs you should look for to know if your hearing aid may no longer be the right option for you? Since the pandemic, we have more and more patients coming our way seeking for a solution. The reason being the face mask. And you probably, some of you experienced it. Even with normal hearing, if I go at the grocery store, there's a nice plexiglass. I have my mask. The clerk has their mask, and I cannot hear anything. Before the pandemic, I don't think many people realized how much they were relying on lip reading. I would even say that some were not just relying, they were actually hearing through lip reading. My best example, I had a patient, she was doing brilliantly. I had one of those clear masks. She could hear everything. And I put her in the booth, nothing. I'm like, wow. And I say, okay, let's try something. I let her see my lips and she could repeat and my microphone was completely off. And I was like, wow, this is why she was with me, because she could not access lip reading and technically she could no longer hear. Another sign to me is when somebody tried multiple hearing aids. Let's say you have worn hearing aid forever, and then at some point you cannot find the right one. It seems like you're trying all those different devices and it's just not good enough. That can be something you may want to look for. Another sign that you could look for, but this one I would say is a bit trickier, is the telephone. When you're no longer to hold a conversation with your family member, with somebody that you know, with a known subject, I find that could also be something you may want to consider, especially before you were able to do it. I'm just saying it's trickier in the sense that sometimes the quality of sound is not great. Sometimes it's just the person accent. I myself have a terrible French accent, which sometimes can be hard to understand. And those are details that can affect your ability to hear. But it would still be something I would consider to say, maybe it's no longer enough. Then a cochlear implant bypass the damaged air cell of the inner ear by delivering electrical current directly to the cochlea or the auditory nerve. A cochlear implant presents a wide range of frequency, regardless of what your hearing was before the surgery. That means even if your hearing was not too bad or in a profound range, should not make a difference for me. For an individual with better low frequency hearing that say, you know what, I kind of like my natural hearing. There is even an option called an hybrid implant where we combine a hearing aid and an implant. Then there's a lot of option when it comes to cochlear implants. There's two parts to a cochlear implant. Then there's the external part that will look a bit like and hearing aid if you want. And then there's the internal part, which we will surgically place under the skin. I like this picture. That will give you an idea, a kind of a better idea. And we have this here being the processor and the external part, and this here would be the internal portion and the electrode. In order to hear from the cochlear implant, you have to remember it is extremely important to wear the external part. Once the internal part is inserted, if you don't wear the external, it won't work. They need to communicate together through the skin by a magnet to activate each other. The cochlear implant program accepts referral from multiple sources. When I discussed with Dorota, which I was not aware before this discussion, not all centers has the same requirement to AuD accept referral. For example, here, we do accept self-referral. We did in the past a patient that for some reason, their doctor or audiologist did not feel the need to refer them to our program. They did self-refer themselves and we did see them. Then there is no such thing as if you refer yourself, you won't be seen as soon. No, you can refer and we'll work with you. Basically, the patient will contact us directly, could be via email, phone. We'll have a brief interview. We'll still ask them some basic question or quality of life. We'll ask them also to send us an audiogram, have an idea what we're talking about. And then we'll see if they are possibly a good candidate. We'll definitely ask them to come in. Even at occasion, when they are not necessarily good or not yet good candidate, they can come and see us. We can discuss with them, talk about option. We'll also, of course, accept a referral from audiologist, family physician, ENT, could even be social worker, physiotherapist. We're pretty open when it comes to seeing patient. Then there are some considerations. Let's start by saying that to some extent, it is always a case-by-case basis. When it comes to who's a candidate, as many factors can influence the final answer. Let's start with age. That's a question that often comes back. We have implanted patients in their 80s, 90s even, with great outcome. And for sure, the general health may dictate if we can or not go ahead with surgery. But this is not our part. Then everybody will be assessed, no matter their condition, no matter their age. We'll see them, and then we will send them to what we call our pre-admission, where they have a consultation with the anesthesiologist, with Dr. Schramm, to make sure that the health is good enough to go with the surgery. Another thing is the duration of deafness. Does not automatically exclude somebody, but in some cases, we may give a bit more counseling to our patient or talk about expectation, depending our long-term. Was the hearing loss? Did you wear a hearing aid? And those are all factors we will discuss with the patient. Something extremely important is to have realistic expectation surrounding the benefit of cochlear implant. Many cochlear implant patients do very well, very, very well. And we can almost always expect better outcome than their current level of hearing functionality. But they can continue to struggle in noise without lip reading or phone. One of the main challenge is before we move ahead with the surgery, there is no guarantee of what your performance will be because there's so many factors that could change your outcome. And we'll chat about it a bit later as well today. Another thing, and once again, I'm going to speak again about it later, is motivation. You may find it weird that we talk about motivation that much, but we could have two patients with the same story, same level of hearing, same age, the same everything. If one is extremely motivated, wears it all the time, come and see me, do their exercise, and the other doesn't, it's not rare that the person that is motivated will do way better than the other. I always like to compare it to a marathon. Nobody, actually, or at least not me, I could wake up tomorrow and say, I want to run a marathon. I would need to train. I would need to take the time to make it better. And then maybe, hopefully, after a while, I could run marathon. I kind of seeing it the same way. You won't put your implant and boom, you're gonna hear everything. It does need multiple appointments. It does need multiple follow-up. And this is something extremely important to understand through this process. What to expect? What's the patient journey at the Ottawa Hospital? For you today, I divided in 4 stages. And the first stages is the evaluation. Then when a patient is referred, an audiologist will be assigned to a patient case. Sometimes it may change, but we really like to build this relationship with our patient. Usually the first person you're gonna see is the one that will follow you across your journey. When we see you, we'll conduct a number of tests to help determine if the patient could be a good candidate. Following this first appointment, we will review the candidacy with Dr. Shrimp, with our team, and try to figure out what more tests you may require. Once we get all the tests back, we will meet with our patient, Dr. Shrimp, to discuss the risk, the complication, but also to sign a consent for surgery if the patient is ready. The surgery is done at the Civic Campus. The surgery lasts approximately 3 to 4 hours. What we usually do is the morning of the surgery, we will meet you in the OR, chat with you, make sure we answer all your questions, and then you will move in the surgery. At the end of the surgery, before the patient gets awake, we will make sure to go down and test the cochlear implant directly in the OR to make sure that we got good measurement, that the implant is working well. And then we can say, we're good to go. We close everything. And then the patient will be going in the recovery room. Usually it's an overnight surgery. We will ask you to stay in the night after the surgery, and you're released the next morning. Many patients find the recovery process to be brief, and usually they can resume their activity fairly quickly. Rehab. Then 1 month after the surgery, we will activate the implant. Then this is done with us, and that's where the process begins. Will it be like YouTube with all the butterfly and you can hear everything? No, sometimes, but not all the time, and that's fine. This is normal. This is why following the activation, you will see me a couple times to make sure we're making things better. Every time the patient is coming, we'll try to adjust it and make it a bit more precise, a bit clearer every time. But it will take some time to get the best result. Lastly, some people did express in the past, what about my audiologist? I've been following my audiologist for 30 years. I feel I still want to follow up with them. You will. At the Ottawa Hospital, we have no affiliated dispensary. What it means is we do work very closely with your audiologist in the community. It's not rare that they will call me, ask me questions, and the other way around. A vast majority of our patients are using an implant on one side and a hearing aid on the other side. And we need this communication with your audiologist to make sure that everything is programmed properly. all the ongoing care and maintenance of the hearing aid is essential. You still want to wear a hearing aid in the other ear. Although we're capable to program your hearing aid, do some maintenance, we definitely prefer to maintain the relationship between your audiologist and yourself. Just because they know you well, they know what you like, and for us, that's important. This is why we work on the implant, they work on the hearing aid, but we make sure to chat with each other to really have the best hearing for our patient. Also, we tend here to do the annual testing, but we do have some patients that prefer to do it with their audiologist in the community, and that's fine. I think the main idea I want to bring here is we're not asking you to terminate your relationship with your audiologist. They know you well, and I'm seeing it more like a team now. I'm going to help you out with the implant, but they keep working with you for the hearing aid to make sure you have a very successful experience. And we're now ready for question. Sorry again, I'm a bit of a chatterbox, and when I get started, it's hard to stop me sometime, but I'm all ready for all your questions. Perfect. I'm gonna look in the chat. I already have one. Hearing aid, there must be some people just live without hearing aid because they can afford them. Will we ever see price come down? Then in the chat, one of the question was why hearing aid are so expensive. There's different reason behind this. First of all, I think when you go see your audiologist, you can always ask for a more ventilated invoice. What I mean by that is, let's say they say it's $3,000. If you look at the invoice, you will notice that the device itself is not $3,000. The device, usually it's somewhere, and that's a bracket, there's cheaper, there's more expensive, maybe 12, 13, 1400. But then you have what we call a dispensing fee. This is basically the salary of the audiologist that will help you with your hearing aid device. You may have seen in the United States, they have what they call over-the-counter hearing aid, which often are not as expensive. The issue, you won't have this ongoing care and maintenance from somebody. Or sometimes you can see unbundling, same idea. That means if you have an issue, either you have to pay for each visit, which can actually be more costly at the end. Then when you're buying a hearing aid, you're buying the device, but you're also buying the specialists that come with it. I think that would explain the price. Also, when you think about hearing aid, you're buying the research that come with it. It's not just like I'm buying a pen, I'm buying years of expertise and research in order to develop this hearing aid. And I think that's why often the price is higher. Why in Canada there's such a long healing period? Different reason. If you look in Quebec, for example, in Quebec City, they tend to activate the processor the day after. And then they will wait, I want to say about a month and see them again. I think it's different way of doing it. One of the main thing is in the first few weeks, you will have a lot of swelling. We could technically activate you the day after. We did in some occasions. Sometimes even myself, I did it after 2 weeks, which is fine. The only thing is because of the swelling, the impedance and the electricity inside and how much electricity we're sending you will change sometime day to day. I guess it's exciting to be activated sooner, but it won't mean that it will be better. I find when we tend to wait, the swelling has gone down, things are more stable and our adjustment are a tiny bit better. Does implant still work if the auditory nerve is damaged? That's kind of a yes and no question. There is some occasion or some centers that will, for example, implant people when they have, for example, vestibular schwannoma, which is a growth on the nerve. The issue with that is as it grows, often the performance will decline, which can be kind of a bummer for the patient. The thing too is, if the nerve is damaged, already when we do a candidacy, we're looking at everything. We can never say for sure if the nerve is fully healthy, but through the MRI, we have a good idea. If the nerve already shows damage, it's just the risk that the surgery is not successful is higher. I think in those situations, it would be really the center that would have to discuss, know exactly why there's those damage. And I think it would really be the center that would have to discuss if it's a good option or not, and ultimately talk about the expectation. I have practically no hearing in my left ear and almost no word recognition. My right ear has 68% word recognition. Would the implant in my left ear help with speech recognition? Once again, I haven't seen your audiogram. I haven't had the chance to speak with you, but quickly, I would say probably. Especially if all your life you weren't a hearing aid in this left ear, and recently it went down. I think for sure it would help, because 2 ears are always better than 1, and that especially in noisy situation. Definitely with this profile, I will say go see an implant center and get an assessment. I think it's worth it. What if some sound are no longer heard at any dB? Once again, I think it's all about your history. If you're not hearing in the past, if your hearing went down in the past couple years, I think it's doable. If you have never heard on one side, the issue is your brain doesn't know how to hear, then chances are it won't be successful. But I would say we did implant some people that had no more threshold and they were extremely successful. I really think it's more about why you no longer have threshold, what happened, since when, and those are the questions we will ask when we first meet you. When it comes to cochlear implant, are patient made aware they will have to set aside fund for a new processor down the road? And how long does a processor last for the average user? Yes, they are. I think that's a great question. When people come and see us, we did prepare what we call our green binder. Once again, this is at Ottawa. I don't know for all this center, but in this binder, there's a section about everything. And one of the section is about funding. It's absolutely true. The first processor is covered, but then when it's out of warranty, it's basically your expense, like a hearing aid. The first processor will come with 5 years of warranty. During those 5 years, there may be some expense. If you want more batteries, stuff like that, there will be some expense, but very little. After 5 years, there are some people that will just keep it. If it works, sound is good, we're good. The thing is, there's always newer technology, especially in the last few years. What was 5 years ago? Oh, just 1 second, there's an announcement. Especially if we're looking in the last 5 years, the changes are huge. This is why usually after 5-6 years, people will come back to us and they are ready to commit to a new processor, but this is up to their discretion. Some people will say, I want to keep it, I'm gonna repair it. This is really to everybody's discretion. Would it help with sclerosis nerve? That's Pat's question. once again, I think this would be kind of in this case by case basis. Ideally, I would say make sure to go in a cochlear implant center. They will do more tests. Usually when the nerve is affected, it's just we already cannot predict the result, but then we add one more layer on what could happen. I think it would all be about how you're hearing now, or well you're doing. If you don't have any word recognition, it's a bit the question, do you have something to lose? Sometimes people does. They still, as much as it's not clear, they can say, yeah, I hear a sound there. Once I do the implant, often there's no way back. As much as we're trying to be delicate during the surgery, there's a chance that you lose what we call the residual hearing. Then I would say it's really to discuss about this with your center and go by their suggestion. Sally asked, how do you test the health of the auditory nerve? There's not a specific test. In this sense, we'll do a hearing test, which kind of give us an idea. But for the nerve itself, Dr. Schramm often order an MRI, and then he can see the size of the nerve. He can see the pathway of the nerve, but there's not really a specific test to tell us how's the nerve. In some cases, for example, auditory neuropathy, in those cases, we can actually see that the cochlea is healthy, but the issue is somewhere along the pathway. But once again, we cannot really say, is it at the connection of the cochlea and nerve? Is it in the nerve? There is not one specific test to specifically say how's the nerve. Which Teresa asked, which CI brand does your clinic implant? Does a patient decide or have input into the brand? Absolutely. Here at the Ottawa Hospital, you choose which make our job easier. Then we will really talk about your lifestyle. We will talk about what you like. I like to see myself as just an helper in this decision. Then just by asking some questions, sometimes I'm able to help you in your choice, but ultimately it's your choice. Extremely rarely Dr. Schramm will recommend one specific device, but that would be in really specific cases. But I would say 99.9% of the time, it's your choice. How effective are cochlear implants in treating tinnitus? Very interesting question. That's Michael that asked this question. Often, patients with tinnitus, when they got their surgery, sometime at first, it seemed a bit worse just because I don't have this access to sound and my brain is seeking for sound. But what we tend to see is once we activate the implant, they actually notice that the tinnitus is going down. For example, one of my patients had his surgery, and after the surgery, the tinnitus was quite loud. Then instead of waiting the 1 month, we waited 2 weeks for him. And as soon as we put the implant, it went down. Not everybody's the same, but definitely we do see in many cases that the tinnitus is alleviated. I have hearing in one ear. Is there an hearing aid to help me? This is Maria that asked. Then in your case, Maria, I think it would be a question on when did you lose hearing on the other ear? Is it new? Is it a long time ago? For example, at the Ottawa Hospital, we started to implant people with normal hearing on one side and hearing loss on the other side. It is an option. Let's say you never had a hearing on one side. I think a cross hearing aid can be an interesting option. The idea of a cross hearing aid, it will take the sound. Let's say this ear I don't hear. It will take the sound on this side and send it to the other ear. Many company is offering cross hearing aid, then I think that's something you could look into. And Pat asked, do the implant processor have to be the same make as the hearing aid in the other ear? Not necessarily. Actually, not all company have ties or relationship with hearing aid company. For example, Medel does not have ties. Cochlear either. They are compatible with ReSound hearing aid, but they are not the same company. Phonak and Advanced Bionic are the only one to be like sister company. That being said, there's always a way around it. If somebody say, I have a Siemens hearing aid, which I love, there's a way. It's harder, maybe it need more accessory, but there's always a way to make it work. Then Wendy said, there is a gap between hearing aid practitioner and cochlear implant. I was told I would not benefit from a CI, but I knew I met the criteria. More education needs to be present for hearing aid practitioner about CIs. Absolutely, I think you're right. Here at the Ottawa Hospital, that's something we have started about 2 years ago, where we're doing presentation for practitioner. That being said, it's up to their discretion if they want to attend or not. Same as Cochlear, they have been doing a lot of work to try to promote implantation. I think it's a bit like everything. Not everybody is interested in those meetings, but there's definitely something we're working on. Here we have Gordana that asked, are patients from Quebec accepted in Ottawa for CI? Yes, they are. Then when patient from Quebec is coming and saw us, we will do an assessment. We do have to ask RAMQ for the ability to do the implantation. As we were saying at the beginning, it's all about the wait time that sometimes is a bit different for the outpatient, out of the province patient. She also asked, do you typically implant one ear at a time? And if both ears require CI, what would be the time period in between surgery? Very good question. Most of the time, we're only doing one ear at a time. Occasionally, we'll do two, especially when it's more time sensitive. If we do one at a time, it's mainly to see how the patient will react with the implant. When we do it, we suggest to wait at least 6 months. I think it's reasonable to just get more comfortable and then we move on the other side, but it can be fairly quick. Can we determine how often and when auditory neuropathy is impacting a child if they are unable to tell us? Good question. I'm working mostly with adults, but auditory neuropathy is sometimes extremely hard to detect. I think in adult, as in a child, the main thing would be when you speak to somebody and as much as they just don't hear. I did have a patient that his hearing was really not bad. It was pretty good actually, but the word recognition was extremely poor. Through more testing, we were able to found that it was an auditory neuropathy. But I would say my best suggestion, if there's somebody in your family, yourself, or somebody you're concerned about, hearing test is the first step. And then if the hearing is normal, but there's still some issue, that's when I would recommend to refer to the audiology department of an hospital to just do more testing. And
Camille,
yeah.
if I could just, we have 1 minute left. So maybe what we'd like to do, first of all, I wanted to say thank you so much, Camille, for taking the time. I know you're in the hospital in between patients right now. So on behalf of Cochlear and CHHA, we really appreciate you coming on today and sharing all this valuable information. We do have quite a few more questions that were direct messages and probably some more in the chat. So I just wanted to let everybody know we will address the questions, and what we will do is send an email after the webinar. We'll make sure that we consult with Camille to get the accurate responses directly from Camille and to make sure all the questions are answered, and we will email that out to all the participants. So again, on behalf of CHHA and Cochlear, thank you so much again, Camille, for joining us today. And for those of you whose questions were not answered, please be assured that we will answer your questions, and we'll send information on how you can connect with our mentors, both CHHA and Cochlear, as well as how you can get in touch with Camille and the Ottawa Hospital Clinic and all the other cochlear implant programs across Canada. So thank you so much, everybody, for joining from across Canada, wherever you might be joining us from. And we look forward to seeing you on our next webinar, which will be sometime in September.